So, welcome to our channel Medicine Demystified MD. We are discussing last minute polls for NEET PG. Today we will discuss pulmonology. So, the pulmonology basics is FEV1 by FEC. This ratio is reduced in obstructive airway disease. Why it is reduced in obstructive airway disease? FEV1 is low, FEC is normal. So, the ratio is reduced. Whereas this ratio is normal in restrictive lung disease because both FEV1 and FEC are reduced to the equal amount. So even though FEV1 and FEC are reduced, the ratio is normal. So that is FEV1 by FEC ratio is more than 80% in restrictive lung disease. It is less than 80% in COPD and less than 70% in bronchial asthma. So less than 80% in bronchial asthma, less than 70% in COPD. In pure ventilation disorders, so these are some physiological concepts. COPD is a pure ventilation disorder. Giving hypoxia will improve oxygen. Whereas in ventilation perfusion mismatch, so example for ventilation perfusion mismatch is pulmonary embolism. Here, ventilation, that is air entry into the lungs is normal, but the blood supply to a particular segment of the lung is abnormal because perfusion is affected by embolism in the lung, pulmonary embolism. Here, giving oxygen will not improve the hypoxia. So even though there is hypoxia, in ventilation disorders, hypoxia will improve. Ventilation perfusion disorders, hypoxia will not improve. This is important physiological concept which will help us to understand the pathogenesis of pulmonary embolism. Told you in bronchial asthma, FEV1 by FEC is less than 80%. Bronchial asthma is an obstructive airway disease, but here there is bronchodilator reversibility. That is, on giving bronchodilators, the reduced FEV1 will improve by more than 20%. Whereas in COPD, here again FEV1 by FEC is less than 70%, but there will not be bronchodilator reversibility. Also in bronchial asthma, inhaled corticosteroids are the main pathology changing drugs. The pathology changing drugs in asthma are called as controllers. So inhaled corticosteroids are the controllers. Whereas we have another group of drugs called as relievers. They only cause bronchodilation, but they don't change the inflammatory pathology. So they are short-acting beta agonist, example salbutamol or levosalbutamol, short-acting muscarinic antagonist, that is ipratropium, long-acting beta agonist, that is formoterol, indacaterol, etc. And we have long-acting muscarinic antagonist, they are tiotropium. Coming to occupational lung diseases, asbestosis is important because it affects the pleura. Initial stages there will be pleural plaques. Later stage there will be mesothelioma, which is a tumor of the spindle-shaped cells of the pleural cavity. Silicosis usually affects miners, construction workers, etc. It causes lung fibrosis of the upper lobe. Lung fibrosis of the upper lobe is typical for tuberculosis. Silicosis mimics TB, also it is associated with tuberculosis. Now coming to another disease, cystic fibrosis is a disease which usually causes bronchiectasis. Bronchiectasis is also an airway disease where there is a destruction of the permanent destruction and dilatation of the airway. Destruction and dilatation of the airway will lead to stagnation of secretions and further infection. So cystic fibrosis, there is mutation of CFTR, that is cystic fibrosis transmembrane receptor channel, which is a chloride channel. The commonest mutation is deletion of phenylalanine of 5-0. That's called delta 508 deletion. This is the most common mutation. Now alpha-1 antitrypsin deficiency is one cause of emphysema. It is actually a cause of emphysema plus cirrhosis. The emphysema here is panlobular emphysema. Whereas in COPD, we get emphysema, that is centri-acinar or centrilobular emphysema. Only the airway close to the central bronchi will be destroyed and dilated in centrilobular emphysema. That is common in smoking. Whereas pan-acinar emphysema is seen in alpha-1 antitrypsin deficiency. So we discussed in asthma, bronchial steroids, that is inhaled corticosteroids, are the main pathology changing drugs. Whereas steroids are not indicated in COPD. They are indicated in COPD only in certain situations. One is asthma COPD overlap. It is a special condition. Eosinophilia is there in COPD because steroids reduce eosinophilia. or when there is frequent exacerbations. Frequent exacerbation is more than 2 exacerbations in 1 year. So this was about airway diseases. Now coming to interstitial lung disease, the most common one is the idiopathic pulmonary fibrosis. Idiopathic pulmonary fibrosis is the disease name. If you see the pathology, that pathological finding is called as UIP, usual interstitial pneumonia. In contrast, we have another pneumonia, that is non-specific interstitial pneumonia. It comes in secondary ILD, that is any systemic disease like SLE causing ILD. But rheumatoid arthritis causes UIP pattern only. This IPF has reticulonodular pattern and honeycombing. Honeycombing is typical of UIP or idiopathic pulmonary fibrosis, whereas NSIP, non-specific interstitial pneumonia, is ground glassing. So ground glassing is we are able to see the airways through opacity. Honeycombing is IPF or UIP. Ground glassing is NSIP. So in IPF, what we give is antifibrotic agents. They are nintedanib and pirfenidone. Pirfenidone and nintedanib. These are the drugs used in IPF. Whereas NSIP, we use steroids and immunosuppressants because NSIP is commonly associated with autoimmune diseases except RA, because rheumatoid arthritis is associated with UIP. Now about pleural diseases, pleural effusion, Light's criteria, that is pleural fluid protein by serum protein should be more than 0.5, pleural fluid LDH by serum LDH should be more than 0.6, pleural fluid LDH should be more than 2/3 of the upper limit of normal. The normal LDH is, upper limit of normal LDH is 300 international units per liter. So 2/3 of the upper limit of normal will be 200 international units per liter. So if the pleural fluid LDH is more than 200, that is also a criteria. So any of this is exudative effusion. If any of this is positive, the pleural effusion is an exudative effusion. There are many causes of exudative effusion. Rheumatoid arthritis and connective tissue disorders cause exudative effusion, but the specific one is very low glucose bilateral exudative. Sorry, I made it wrong here. It is bilateral exudative pleural effusion. Usually, bilateral effusion will be transudatic. Example in heart failure, CKD, hypoproteinemia, etc. But exudative is usually unilateral. But a condition where we get bilateral exudative pleural effusion is rheumatoid arthritis. Now about the other pleural disease, which is tension pneumothorax. It's not pneumothorax, it is tension pneumothorax. It's an emergency. Why it is an emergency? It causes hypotension, elevated JVP and absent breath sounds, because when lungs get collapsed due to tension pneumothorax, the lungs will not get filled. So JVP will be elevated and blood will not enter from the lungs to the heart. So there will be hypotension. The treatment is immediate needle thoracostomy followed by ICD. And about mediastinal tumors, at least if you remember, thymoma is an anterior compartment tumor, that is enough. Now a disease about point about obstructive sleep apnea. It is diagnosed by sleep study, also called as polysomnography. What we measure in polysomnography is an index called as AHI, apnea hypopnea index. So it measures the number of apnea hypopnea events in 1 hour. If the AHI is 5 to 14, it's mild OSA, 15 to 29 is moderate OSA, 30 or more is severe OSA. When thinking about OSA, we should know about the recent FDA approved drug for OSA, which is tirzepatide. Tirzepatide is a GLP-1 and GIP receptor analog, which is used in diabetes as well as obesity. It is the latest advancement. It's an injectable drug. It is FDA approved for OSAs because obesity is the commonest risk factor for OSA. So if patients having OSA, we have to give tirzepatide. OSA is also called sleep disordered breathing. The most common cause of lung transplant is COPD still. And about ARDS, a criteria called Berlin's criteria is used to diagnose ARDS. ARDS is actually non-cardiogenic pulmonary edema. It clearly gives. That is, there is pulmonary edema in X-ray, but there is no elevated pulmonary capillary wedge pressure. So, pulmonary edema like picture in X-ray plus pulmonary capillary wedge pressure should be less than 18 millimeters of mercury. The criteria, that is Berlin's criteria, is there should be low PF ratio less than 300. If it is 200 to 300, ARDS is mild. 100 to 200, ARDS is moderate. Less than 100, ARDS is severe. The second criteria is the onset of this hypoxia should be less than 1 week of a disease. The third thing is there should be bilateral lung infiltrates, which should not be explained by any other finding. So how will you treat ARDS? Is a ventilation strategy, that is low tidal volume and optimal PEEP. Some books say it is high PEEP, but the actual wording is optimal PEEP. So low tidal volume, high or optimal PEEP is the strategy, because this prevents volume trauma to the lung. Now about pulmonary hypertension. When do you say pulmonary hypertension? Mean pulmonary artery pressure more than 20 is pulmonary hypertension. What is portal hypertension? Portal vein pressure more than 10 millimeters of mercury is portal hypertension. So pulmonary artery pressure more than 20 is called pulmonary artery hypertension, and pulmonary vascular resistance more than 3 Wood units is pulmonary hypertension. It is of 4 groups, group 1, 2, 3, 4. Group 1 pulmonary hypertension includes primary pulmonary hypertension due to congenital heart disease, and pulmonary hypertension associated with connective tissue disorder. Group 2 pulmonary hypertension is pulmonary hypertension due to left atrial dilatation, that is pulmonary hypertension due to left heart diseases. Group 3 pulmonary hypertension is pulmonary hypertension due to chronic lung diseases and chronic hypoxia like ILD, bronchiectasis, COPD, obstructive sleep apnea. Group 4 pulmonary hypertension is chronic thromboembolic pulmonary hypertension. Now about lung tumors. Small cell carcinoma is very important because it causes most of the paraneoplastic manifestation like Lambert-Eaton myasthenic syndrome. It can cause SAADH and hyponatremia. But squamous cell carcinoma is the only carcinoma in the lung which causes paraneoplastic hypercalcemia. So all paraneoplastic manifestations in lung are due to small cell carcinoma except paraneoplastic hypercalcemia, which is due to squamous cell carcinoma, because this cancer secretes PTHRP, parathyroid hormone related peptide. About pneumonia, one point to remember very much is whatever be the cause of pneumonia, be it a community acquired outpatient pneumonia, an admitted community acquired pneumonia, hospital acquired pneumonia, ventilator acquired pneumonia, or a HIV person having pneumonia, or an immunosuppressed person having pneumonia, the most common cause of pneumonia overall is Streptococcus pneumonia. Okay. Other pneumonia should be suspected in specific situations. For example, Legionella pneumonia should be suspected when there is history of exposure to AC or a travel or some cruise. Pseudomonas aeruginosa should be suspected when there is any pre-existing lung disease like bronchiectasis, or when there is a COPD. Any previous lung disease, if there is a pneumonia, think of Pseudomonas